This is my bow tie right here. If he's looking.
Oh, God.
Usually if you walk out.
That's fine.
She's like making a little process, like a 3-hour long process.
Yeah, you might bring me more food every now and then.
Okay, guys, thank you for staying over and watching my presentation. My name's Rebecca. I know a couple of your faces, some of you guys have never met before. I am a student at the University of Cincinnati Blue Ash, and I am currently finishing up my bachelor's degree in radiology. So this is a final presentation I have to do in order to graduate, and I chose pediatric imaging because I do work at a pediatric hospital. So some objectives, after listening to this presentation, you should be able to apply the topic of imaging pediatrics to everyday work. You will work with peds, maybe not as often as some people, but you will work with peds. Explain to parents of pediatric patients approximately the amount of radiation their child will receive. Parents are very worried about radiation for some reason. They watch Dr. Phil, whatever, they get worried. Name an organization that specializes in pediatric imaging. There is one organization that is specifically pediatrics. Implement at least one strategy to safely image the pediatric patient, such as immobilization tools, sedation, and other techniques. And then finally, modify pediatric imaging protocols in place to best suit pediatric imaging. Most machines are set up for adults, so you need to know how to switch your techniques down to a pediatric setting. So a little introduction into pediatrics. Pediatrics are completely different than adults. Who has worked with a child so far? Okay, good. And you guys say that kids are definitely different than adults. Okay? So you will work with peds, you will work with adults. You need to know the difference on how to image them. Kids are not going to do as they're told, always. Sometimes you get a good kid. But whereas adults, you can say, take a deep breath in, hold it. If you're working with a 2-year-old, they're just going to scream and you're not going to be able to tell them to hold their breath. So you need to know how to work with peds and adults. You also need to be able to address radiation concerns. The simplest way I address radiation concerns, because I do have some kids who always are like, am I going to glow after this? No. What I will say is, do you know what a sunburn is? And they're going to be like, yeah, I know what a sunburn is. And I say, a sunburn is a radiation burn. I'm not going to give you a sunburn. And they'll be like, oh, okay. This is the simplest way. Communication. Kids get scared. You need to know how to communicate with kids. You don't want to go and say, shoot that x-ray. Kids can be scared. You may want to say, we're going to take a picture. Finally, immobilization. This is going to be your friend. You need to know how to take down a kid, pretty much, so that they don't move. Because you don't want to have to hold when you are able to hold. You don't want to have to hold for every x-ray. You need to know how to use different tools. Parents are going to be your best friend. Child sizing techniques. So, like I said, most machines are set up for adults. So, tell me a technique for a chest x-ray. Anybody, shout it out. 120 at 2? Okay. So that's for an adult, an average size of adult. 120 at 2 with the grid. For a kid, 4 inches is when you use the grid. A little baby chest isn't exactly 4 inches. So a technique you may use for a pediatric is 50 at 0.8 or something like that. So you need to know how to set that technique because it's a lot different than adults. So radiation, is it worth the risk? There are small risks to receiving radiation versus the big benefits you may get from a diagnostic image. So parents are terrified of radiation, like I said. So you need to explain to them that this tiny little amount of radiation that your kid is going to receive, it's not comparable to us diagnosing what is wrong with your kid. Would you rather them receive a tiny amount of radiation that probably won't affect them in the long run, or not diagnose a pneumonia and your kid ends up in the hospital? Radiation doses. So annual limits for a radiation worker, it's 50 millisieverts. For the general public, it's 1 millisievert. So general public is your patients, parents holding patients, nurses, anybody helping you. Radiation workers are you guys. These are approximate doses. These are adult doses because they don't really get the pediatric doses because they don't want to do radiation studies on peds because radiation isn't the best. So approximate doses for a chest x-ray, it's 0.1 millisievert. And for an arm or a leg x-ray, it's 0.001 millisievert. So considering this is how much they can have in a year, and this is how much they may receive for a chest x-ray, it's not that much. You would have to get hundreds of x-rays to hit your dose. So Duke University Medical Center did some research. They followed 337 children under the age of 6 who all had heart disease. Heart disease patients are going to be followed. They're going to get multiple x-rays, multiple CTs, multiple different radiation studies. So of these 337 children, total, they got 14,000 imaging procedures. Of those 14,000 imaging procedures, the cumulative dose of radiation is lower than the annual background exposure. Annual background exposure, sun, radiation from vegetables, fruits, blah, blah, blah. You're not going to get as much radiation with these x-rays as you are from being outside. They decided to follow heart disease patients because they are getting radiation. It wouldn't make sense to follow a healthy kid and make them have all these imaging studies. So background radiation. We receive radiation every single day. These are low energy forms of radiation, but it is still radiation. The sun, number one. That's why you can't take your dosimeters and leave them in your car, because it is going to measure that radiation and add to your dose. If you do leave it in your car, put it in your glove box. ALARA stands for as low as reasonably achievable. Your 3 parts of ALARA are time, distance, and shielding. You want to decrease your time as much as possible. That is even more important with peds because they move. The quicker your exposure time is, the less chance of getting motion, the less chance of having to repeat, less radiation. Distance. You want to increase your distance, less radiation dose. And shielding, especially on peds. You want to shield them because they have not hit reproductive age. So you want to shield those reproductive organs because they are still dividing. Dividing cells are more radiosensitive. So they have a higher chance of getting cancer in those reproductive organs. So here is another study. It's cervical spine dose study. So whenever you have a cervical spine injury, such as a trauma, CT is the modality of choice for getting images. 90 to 200 times more radiation than plating radiographs. That's how much more radiation they will receive in CT. And it's up to 200 times more radiation to the thyroid, which is equal to about 6 to 11 millisievert depending on the age. Okay? So, kids, their neck isn't very stable yet. They don't even get an odontoid until about age 4. So their head is very wobbly. So they are more likely to receive a cervical spine injury. You get the same information doing a 3-view C-spine film as you do get in a CT. Now, if it is a more serious thing, they are going to skip the X-ray and go straight to CT. But if they can get away with doing just a C-spine X-ray study, you're going to save so much radiation for this kid. You're going to get 90 to 200 times less radiation than going straight to CT. Sometimes at my hospital, we see where they get an X-ray and a CT, which is stupid, but you can't tell doctors no. Radiation sensitivity. So children are more sensitive to radiation. They have a long life ahead of them. So this means they are going to receive more X-rays in their lifetime. So more dose throughout their lifetime. Rapidly dividing cells are more radiosensitive. Kids are growing, their cells are dividing, they are more sensitive. Image Gently, we're going to talk about. Image Gently is the organization set up specifically for pediatric imaging. The FDA has a proposal, and they want to make devices specifically for children. They want to make CT devices, fluoro devices, and general X-ray devices. They are working with the Alliance for Radiation Safety and Pediatric Imaging to try to figure this out. The problem is, it's going to be the opposite of what we got right now. So right now, machines are made for adults, and you have to set techniques for kids. My hospital, we do anywhere from tiny little babies that are this big to 40-year-olds. Because if you are a long-term patient, such as like a heart patient, they're going to follow you your entire life. So if they're making devices just for kids, then you're going to have to know how to set adult techniques. So are doctors the problem? Up to 40% of CT scans are ordered unnecessarily. Why do you need a CT of the abdomen when they could go to ultrasound and receive no radiation and look at the exact same thing? Why can you get a C-spine X-ray and they still order a CT of the C-spine and they're going to get 200 times more radiation? An online clinical scenario was conducted where doctors were given a case. The case was a 6-year-old with painful, non-traumatic hematuria. Doctors were given the option of ordering either a CT of the abdomen and pelvis without contrast or an ultrasound of the kidneys and bladder. CT is 3 to 10 millisieverts, whereas ultrasound is no radiation. CT was the first choice until doctors were told about radiation dose. Once the doctors were told how much radiation this kid is going to get by getting a CT instead of an ultrasound, they all switched to ultrasound. Now, ultrasound is limited, but it's a better choice to start with an ultrasound, no radiation, and then maybe eventually work up to a CT. So radiation, alternatives, ultrasound and MRI. Ultrasound, it's good for follow-up studies, such as maybe you have a kidney stone. They can follow you up with doing ultrasounds of your kidney and looking for that kidney stone instead of doing x-rays every couple weeks. Less radiation, no radiation. Or MRIs. MRIs, no radiation, but it does have limits. If you have a metal implant, can't do it. If you may have been exposed to metal in the eyes, can't do it. And with pediatrics, MRIs are a lot longer, so you may have to sedate the patient, which is a whole nother issue than radiation. So the Image Gently Alliance was founded in 2007, and the goal is to lower radiation to pediatric patients. The Image Gently Alliance has a website. You can go into it, you can pick your modality, and it will give you tips and tricks on how to lower a dose. It'll give you different technique options. It will say you can immobilize your kid like this. It will suggest doing this image study instead of this image study because it's less radiation. You can just go on that website and it gives you all kinds of different things. So this is an example from the Image Gently website because CT is the most radiation a pediatric is going to receive. So it gives you 5 steps in reducing radiation doses in CT. The first step is increase awareness for the need to adjust radiation dose to children. Like I said earlier, even for just regular x-ray, you are gonna use a third of the dose as you would for a patient. So you need to know when to adjust your technique. Now, if you have a 16-year-old patient who is the size of a 40-year-old patient, you're not gonna adjust your technique. You're just gonna use the adult technique. Be committed to make a change in your daily practice by working as a team with your radiologist, physicist, referring doctors, and parents to use the appropriate radiation dose. Your physicist can go in and adjust your doses and your techniques. They can set up protocols for pediatrics. I know at the hospital I work at, they do have protocols for pediatrics that their physicist and the radiologist set up. The radiologist wants the images to look like this. The physicist decided a technique to make those images look like what they want. Know your practice standards. At some hospitals, the radiologist may want an image to look like this. At other hospitals, they may want it to look like this. At my hospital, for head CTs, the doctor is okay with some modeled images as long as they can see brain bleeds. That means the kid's going to receive less radiation, but the doctor can still see what they need to see. It's all depending on how a doctor wants to look at it. Work with your physicist, radiologist, and department manager to review your CT protocol. So, have any of you seen in CT, I don't know if any of you have seen CT, but at some of the littler hospitals you can go and look at CT, where they reconstruct like a 3D image. Yeah, okay. So I know at my hospital, traumas, they have to have the 3D reconstruction, whereas just a regular kid walking through the door for an outpatient, they don't. That is all because that is what the radiologists and department managers want as their protocol. Okay, so you need to know the different protocols, because why do a 3D reconstruction on a patient who just walked in as an outpatient when they don't need it? That's more radiation. Finally, be involved with your patients. Like I said, patients, pediatric patients specifically, get scared. They don't want to hold still. They're going on this table that's going to take them through a giant, loud machine that's spinning around their head pretty much. You need to be able to tell your patient what to expect. I know at my hospital, they say they're going to go on an airplane ride because it sounds like an airplane. That gives them a little more confidence that, oh, I can lay here, it's not going to touch me, it's just going to sound like an airplane, I'll be fine. The more you explain to your patients and the patient's parents, because sometimes the kids are too young and they're not going to understand what you need of them, the more likely they are to understand and do what you need. So preparing the child. Dress appropriately. That is something parents can do at home, okay? Kids get uncomfortable very quickly. especially kids going through puberty. They may not want to sit there and get changed into a gown. So if before coming in for an x-ray, the patients are, or the parents are like, okay, we need no metal, we need to take off your jewelry, we need all this, then they may be a little bit more comfortable getting their images because they are ready, they don't have to change, they're good to go. X-rays are also fast. Parents need to explain that to their kids, that x-rays are gonna go really fast. Yeah, it may take a few minutes to get your arm into the correct position, but once it's there, it's gonna take less than a second to take your picture. Okay? Especially kids who are broken. Say you have a kid come in and their arm is at an L, their forearm's at an L. They are terrified to move their arm. So if you can really quickly just move their arm the way they are, or the way you need them, and then very quickly move it back, they're usually fine with it. You just gotta say it's gonna be really quick. Communication. You need to gain their trust, like I said. You need to get on their level. If you have a tiny little 2-year-old all the way down here, and you're looking down at them and talking to them like, I need you to do this, I need you to do this, they're gonna get scared. So you wanna bend down to their level, get face to face with them, and tell them what you need. Simple language. Like I said, don't say shoot the x-ray. They're gonna get terrified. They're gonna be like, what are you shooting? If you say, we're gonna get your picture, they'll be fine with that. If you go, say cheese, they love doing that. They think they're getting their picture taken. Say cheese. Tell them what is gonna happen. So, say you're doing a chest x-ray. Say, you want to sit them on a stool in front of the wall bucky. Be like, I'm gonna sit you on the stool. We're gonna put our back against the board. I want your arms out like an airplane, and you're gonna hold still. They can usually do that. And then tell them what they have to do, okay? So say you are trying to do a soft tissue lateral neck on like a 4-year-old. You want them to take in a nice inspiration, but they're not gonna understand taking an inspiration and hold it. What you may wanna say is be like, why don't you sniff the flowers? Taking a long sniff those flowers. That will get you your inspiration, and it will also tell them what to do in simple terms. Children don't always follow directions. So, breathing instructions. If you have a tiny little 3-month-old on your table and you're trying to do a chest x-ray, you can't be like, hold your breath. Can't do it. What you're gonna have to do is time your exposures, okay? So get on the rotor, start breathing with them, and then when they take a deep breath in, hit the button. It will take practice. It will take a while to understand and like get with their breathing, but once you figure it out, you're gonna get good inspirations every time. Holding still. Kids aren't gonna always hold still. So that's when you have to use immobilization techniques. Immobilization tools. Parents/technologist holding. Always go with parents first. But kid may not have a parent with them. Mom may be pregnant. And dad may just not know what he's doing. So sometimes technologists have to step in and help hold. So that's when you hold them down tight and tell them to hold still. Tape will be your best friend. Tape will be your best friend, I'm just gonna say that. You're gonna wanna tape them down. Sandbags. You guys have seen sandbags and stuff. So, say you're trying to do an ankle x-ray and they just keep internally rotating their foot. So they keep kind of doing oblique, but you want a straight AP. Take a sandbag and put it against their foot so it's straight up. That way you're getting the image you need without anybody holding. Take a stat. Take a stat. At my hospital, we don't use Picostat. We don't even have one in the hospital. We use something called a Columbus board. I know a couple of you have seen the Columbus board. So the Columbus board is pretty much just a plexiglass, and it has little feet on it. And what you do is you lay the patient on it, you wrap their legs in blankets, and you tape them down. It has enough room for you to slide the cassette underneath it so you can get an AP. And then you put it for a crossfire and do a crossfire lateral. It's a little less dramatic than that. And it's called Columbus board because it was designed here in Columbus at Children's Hospital. Sedation is your final technique for immobilization. It's also something you do not want to do if possible. We have a MRI simulator, and it's pretty much just a big wooden machine, not a machine, a big wooden table thing, and it has speakers built in it that sound like an MRI machine. If you're an inpatient or even outpatients, they will bring those patients in and do multiple trials with that machine, that test machine, before they do an actual MRI. That lowers the sedation rates a lot. I don't remember the exact numbers, but last time I heard, which was about 2 years ago, they were doing about 75% less exams with sedation. Sedation is used for longer exams. It is very risky, especially for cardiac patients. We get a lot of cardiac patients. There's different sedation rates that you can use, and it's all dependent on what kind of patient you are. They try not to do it as much, but say you have a trauma come in and they don't have time to go through that test machine. They're just going to have to go straight to MRI, so they may have to sedate the patient for the MRI. So, in conclusion, kids are a lot different than adults. Would you all agree? Yeah. So you need to know how to work with the kids, how to work with the parents, how to adjust your techniques, how to immobilize kids, and there's a million different things that you will learn throughout the years. Okay, any questions?